We're going to make this one interactive. I know that we're all tired, and we appreciate you sticking around. Definitely, I'll take less than 15 minutes. Hopefully, we can all agree on some of these principles, way less controversial. And I'm going to start by asking 4 questions. And we're going to do a show of hands. Pulmonologists, thoracic surgeons, hand up in training or board certified or some sort of, okay. If it's a no, lower your hand. Have you been consulted for an airway fistula ever? Yeah, okay. Did you treat that or did you refer somewhere? Yeah. And the question is, are you pleased with your results? No. I don't think that the treatment or the understanding we have of airway fistula is optimal, and I think that there's a lot of wiggle room for us to do it much better. So here we go. Definitions. Most of the talk is about airway fistulas. We're going to have a word about alveolar pleural fistulas, especially for the fellows that are training, and it's important to be able to call conditions by their name. So it's important to differentiate a bronchopleural fistula, which is somewhere in the airway visible to the scope, than an alveolar pleural fistula, which is in the surface of the lung. And we're going to have a little bit of conversation regarding tracheoesophageal and bronchoesophageal. Definition also, it's important for all of us to understand that a prolonged air leak is any leak that you see in your canister or your atriums beyond 5 days. Here we go. Patient shows up in the emergency department, urgent care, x-ray, lung is down, maybe an EGD performed a couple of days prior, symptomatic, short of breath, maybe hypoxemic, and we as consultants get called and say, now what? So as they're getting ready to put a chest to set, we need to consult on this, the sooner the better, since this patient is not doing very well. We're going to be kicking in gear for all our training in pulmonology and ICU, and we're going to say, okay, let's get this patient stable. That's important. Let's not think about stents or surgical referrals. Let's get the patient stable, ABCs. Sometimes patient is losing their entire title, and we need to mechanically ventilate this patient. As we're stabilizing, part of the stabilization is to get chest tubes and get ready to place them, whether you do percutaneous, whether you do dissection, whether you believe in an approach being better than the others. As we're getting all of these things, we're getting the patient somewhat in the work for getting admitted, and depending on where you are, there are some other doctors that may be made aware to approach this in a multidisciplinary fashion. We are all hoping for the best and preparing for the worst. We have backup plans, and immediately we start thinking short, medium, and long term about this patient, which we still haven't done a bronchoscopy, but we'll get there eventually. So how are we going to move forward? One of the reasons that we have to spend a little bit of time on the phone with whoever is calling us is just get an idea of what's going on with the patient. Is this the patient that has a parenchymal problem? Is it the patient that has had cancer before? Is it the patient that was radiated? Is it the patient that just had a car accident and he was brought here? Definitely is somebody that underwent surgery a few days ago and was discharged. And if we're getting called from a peripheral hospital that the patient has been in the ventilator, we need to figure out really what's going on and for how long, and if they have been seeing this kind of brewing or is a sudden change. Initially, we need to think about 3 aspects. Is this going to be a conservative approach? Are we going to approach this endoscopic, bronchoscopically, or are we going to do a surgical approach? And sometimes it's sequential. Part of the conservative treatment is draining the pleura, start thinking if there's going to be antibiotics or antifungals or whatever is it that you have to give. If the patient is malnourished, especially if he's been in the ventilator for 3 weeks, is the patient able to heal from what's going on and now he has a hole somewhere or protein depleted and this is never going to heal in any way. Importantly, especially for the ones that practice intensive care unit, we in the US, our training for the most part is dual pulmonary and critical care. So if the patient is ventilated, then there's some considerations that definitely I invite you to read. This is everything has to do with shunting, VQ mismatching, correcting acidosis, management of the PEEP, and definitely management of possible pleural or mediastinal spaces infection, and everything that has to do with protecting lungs or airways from further damage. This is a very complex topic that I don't believe that 15 minutes is enough. Definitely, there are some salvage approaches on ventilators that I invite you to read one of the many, many sources of truth, which is expert opinions and maybe some case series in which there are salvage approaches that can definitely save a life. And this could be either putting the patient on ECMO, whether it's a single lung ventilation, and back from H1N1 and different type of pandemics that affected the lung, we learned a lot about oscillators. So nobody likes to hear that piston, but we have seen that some alveolar fistulas heal faster on oscillator. So one of the cornerstones of addressing fistulas, especially alveolar fistulas, is try to make the patient from positive to negative pressure as soon as possible, as to prevent this gradient that will perpetuate the fistula from healing. And definitely, if we're on the quest of finding where the alveolar fistula may be, we have in the US, and I'm sure that some others have, jetting oxygen to try to exacerbate that leak that we see in our canisters. So the size of the chest tube matters. I hope that all of you are well versed in putting small chest tubes, pigtails, in order to drain, and we're not necessarily cracking it open and dissecting in a surgical fashion. Definitely more dramatic, and maybe that's all you have. But definitely for this type of problems, trying to do the smaller appropriate size, especially directed to where the problem could be, is preferred over a surgical chest tube. Let's manage some of the symptoms. Daily x-rays and see if the lung is collapsing, and does the x-ray correlate with how the patient is progressing? And if the pleura is not having good apposition, visceral and parietal, why is that? Is it a trapped lung or not effective suctioning? Are there pockets in there? So all of those are questions that we have to ask ourselves. I promise we're going to get to the stenting in a second. And every time that you have a fistula, we favor, especially interventional pulmonologists in the US, to have the least amount of suction possible in order to stabilize or improve, and definitely water seal over suction. Depending on where you are, you're going to have immediate management with some sort of drainage system where it's digital, in which you can dial up and down with click, enter the negative pressure, or you're going to do it the old-fashioned style with the atrium. Both of them will provide you with an idea of the suction and the leak, which is important. This is where definitions matter. This is where we have to speak the same language. For alveolar fistulas, which matters in a way that we need to know for how long the alveolar fistula has been in there. Anything less than 7 days, we have some degree of hope that it's going to heal. Anything more than 10 to 14 days is very unlikely to heal on its own. How much is it leaking? The volume. There's grading systems I'm going to show you in a second. And the trend. Is it getting a little bit better every day? Is it getting a little bit worse every day? Or is it stable? When it comes down to the bronchofistulas, then leaking, even though the leak is going to be there, it should be fairly constant. Usually bronchofistulas take way longer to heal than alveolar fistulas. And that's where bronchofistulas, the size, location, and overall characteristics of that fistula matter in order for us to figure out how we're going to treat these patients. Whenever I'm training my fellows, and one of the questions that I have before they present me the patient in the morning is, how is the leak? Is it better? Is it worse? I really don't mind any scoring system for as long as they go and they physically take a look at the reservoir, at the atrium, and they can tell me if it's better or worse. And I'm going to push a little bit. I'm going to say, okay, what grading system you may use, and is this a grade 1? Is it a grade 4? And obviously, whenever you're in training, all of those things are something that you may punt for the future, but training is the time that you have to get good at this. So whether you use any classification, we have to document in the chart how is the fistula progressing. Are we doing okay so far? Good. We talked about short, medium, and long term. In the short term, we all put patients either on suction or low volume suction. Hopefully, we're going to move to water seal, and eventually, we may be able to clamp those patients to get the chest tube out, particularly in alveolar fistulas, or whenever we heal the bronchopleural fistula. These devices are more when we started de-escalating, since it doesn't require necessarily any suction. To the left, you have a Heimlich valve. I humbly suggest that you take a look at this if you have them and understand very well how this works. We have seen some disasters happen when the Heimlich valve is put in line with the chest tube into the atrium, and by the fact that it's backwards, the patient has a tension pneumo. So please, know your devices before you put them on a patient, and if you think you know it, just look at it again, especially if you're in training. To the right, we have different type of versions. You have a pneumostat, a mini atrium express. All of these are devices to the right that the patient can go home with, but they will only be able to go home if they are off suction. So there are some devices that can be used in order to get the patient home and maybe give them a couple of more weeks to see how they do. There's some alveolar pleural fistulas that can take longer to heal, and maybe some patients don't have enough lung for us to take offline by putting endobronchial valves, which is what we're going to be talking in a second. Okay, we're all here, we all love bronchoscopy, and we feel that we can heal and we can help patients bronchoscopically. Therefore, the basic approach of this is, first of all, let's localize where the problem is. Is it right? Is it left? Is it upper lobe? Is it lower lobes? Where there is a visual inspection for tracheobronchial pleural fistulas, or whenever we do balloon occlusions in alveolar pleural fistulas, and to say that you located and isolated the fistula, you need to make sure that the leak that you observe in your atriums or in your canisters or reservoirs decreased by 50%. So if you have bubbles every 1 second, now the bubbles are every 2 seconds or 3 seconds. You don't have to fix the leak. And this is a little bit of a problem that we all have to be mindful that the isolation of fistulas may not be possible. Maybe you are in the right upper lobe and that's where the alveolar pleural fistula is, and there's not enough fissures, and for those that have the possibility of performing charties to see if there's collateral ventilation, that will play a significant role. Maybe you are not very aware of exactly what I'm talking about, but charties is a pressure gauge system in which you balloon occlude and you sense distal pressure, and if there's collateral ventilation, it doesn't matter if you block an upper lobe. If there's collateral ventilation, the right lower lobe and the right middle lobe may feed that area that is diseased, and you're not going to see any decrease of the leak. Sometimes we have used methylene blue to just squirt methylene blue. This is not permanent. This is not something that is going to last forever. And you can see the methylene blue coming out of the chest tube, and that may have been used by some of you. And if you don't, just keep it in your back pocket. Okay, so let's talk about therapeutics. The therapeutics for alveolar pleural fistula and bronchopleural fistula are completely different. We do not have enough time in 15 minutes to go in detail. I invite you to take a look and read. The bottom line is the treatment of airway fistulas is usually local, or for the most part local, where the alveolar pleural fistulas are more along the lines of endobronchial valves or surgical. There's a lot of case reports. We all have experiences that we did one-off and we publish it, but I invite you to read the literature and see really what's the standard of care and what are your options before you give a patient what you have. Maybe there's something better somewhere else, and the patient will definitely appreciate you referring the same way that you will appreciate if they refer to you when there's something that it would be preferred. Okay, we're going to talk about devices, and we're going to take 10 seconds per. Platzer devices, especially in big fistulas in the airway, that they have very few options. Some smaller surgical fistulas in the airway, application of silver nitrate, that works really well. We do not have enough time in the entire day to talk about how to stent somebody, but definitely stenting has been a preferred mechanism of occluding the fistula in order to either permanently exclude that area that is a concern, or temporary until you figure out what the next step will be. We don't have this in the US. Watanabe, Spigots, these have been used with really good success. I've read anecdotal reports in which some patients have had valves and they have put bone or they have put surgical foams in order to create a plug. Definitely a multidisciplinary approach and discussing with experienced doctors may be really, really important for you to know how to plug a hole. Coils have been used. I don't have experience in coils, and that's the way that they look. So if you have an experience on coils, definitely an option in order to close off a bronchopleural fistula that otherwise is not going to heal on its own. For alveolar pleural fistulas, we have both Zephyr and aspiration valves, and they come in different sizes. We have used both for isolation. One school of thought is that you just occlude the segment that is affected. Some are more aggressive, like myself, that we like to occlude a lobe for as long as the patient allows for that. And then just to wrap up this and get into the interesting part of the how do we do some plumbing on these diseased airways is we need to know where the fistula is. To have it in the mid-trachea or have it in the carina or have it in a subsegmental area is not the same, and treatment options are going to significantly vary. Whenever we take a look at the congenital and pediatric population of esophageal atricias, you can see that developmentally there can be connections between esophagus, stomach, and the trachea and bronchi. So it's very important that we do a very good bronchoscopic exam and see where the hole is. And definitely whenever you start taking a look at all of this, you can see that we all have seen holes that are either leaking bile or are bubbling, or you see the esophagus, and we know that immediately we need to start thinking, how are we going to palliate this? This is not sustainable. To the left is what you don't want to see, that you put whatever stent you have in your shelf, and then the stent is doing nothing, and you can see the esophageal stent popping in there. I am very well aware of the school of thoughts that for bronchoesophageal fistula, some doctors prefer to stent the esophagus and the bronchus. In my experience, and having done hundreds of these cases, I always approach this as what is the least amount of stenting that we can do in order to get a good outcome. So have we done double stenting? Yes. Do I prefer to have GI to do an esophageal stent, and hopefully that occludes enough of the esophagus in order not to leak into the airway? Yes. So all options are on the table in order to secure an outcome with the least amount of invasiveness. You can see how there can be a little bit of pressure in that poor mucosa in between the bronchial area and the esophageal whenever you have radial force that is expanding, and that's going to cause a little bit of ischemia in that area as a byproduct of pressure. So a little bit of a history of gastric barium and seeing how the left mainstem starts getting a little bit of a contrast in there. We don't want to see this. In wrap up, there's two ways to go about this if you're thinking that stenting is the way to go. You can do rigid bronchoscopy or fiber optic. If you're going to do rigid, please make sure that you know what you're doing. There's an operator inexperienced that in order to put a stent, maybe you want to put a silicone stent, and that may not be a good outcome. So there has to be reasons for you to do rigid. One of the reasons that I can think of is going to be if you have silicone stents only and you have a situation that you cannot refer the patient to have some sort of a different approach, obviously you're committed to rigid. In the US, we're very fortunate to have self-expandable Y stents, especially for those carinal areas or very proximal main stem that you know if you put a straight self-expandable metal stent or a silicone stent, it may migrate or it may not occlude. Even though they are significantly more expensive, this can be deployed with a fiber optic bronchoscopy, with an endotracheal tube and do everything under fluoroscopy. I have a video of one of my colleagues in the US that places a rigid in order to deploy under visual inspection. My approach to put self-expandable Y stent is to do it with a large endotracheal tube and do it everything under fluoroscopy. Surgical approaches, unfortunately we're running out of time and there's a lot of speakers that have great things to share with you. Definitely involve your surgeon early on before we start doing a lot of this, and then make a consensus decision that the best way would be either temporize leading to surgery or maybe directly going to surgery and not instrumentalize an area that is already diseased. Last but not least, pleurodesis, especially in some cases, is necessary. Therefore, whatever pleurodesis you're aware of the chemical or maybe blood patches, it's important to consider pleurodesis as to prevent problems in the future. Definitely the effectiveness in alveolar pleural fistulas that recurred after the second or third episode, we're pretty committed to at least entertain and discuss with the patient. Last slide, prevention and follow-up. Whatever environmental factor is making the lung continue to be diseased, manage the device in any way. Whenever you put a stent, this patient has to be followed. Whenever you have a Heimlich valve, the patient has to be followed. Have surveillance protocols. The patient gets discharged, cannot go home forever. They have to come back for you to either take valves out or take the stent out or refer to surgery. We do not like patients with devices that we place not following up either with us or somebody that will own them. And the precautions of somebody that has devices of, for example, recurrent pneumothoraces and air travel after procedures. Last but not least, thank you for you to endure a long day of lectures. Thumbs up for the organizers and our docs that work in Yashida hospitals. And if you have any questions, that is my contact email, and I hope to see you on the next Broncos. Thank you for your attention.